Hit record. The first thing that I want to tell you guys is, for the most part, I am very, very, very proud of the work on the coding packets. Like we talked about, hang on, one of the ladies. I just lost y'all. I'm trying to log back in. Okay. The biggest thing was to go out and research what you didn't know, and then code what you knew and organize your time and kind of break it up. Because when you code or anything in a medical office, if you're a biller, even if you're up front, there are going to be tasks that you have to organize into what's priority, what you need to do first, and you have to be able to concentrate for long periods of time. So I just want to say, give y'all a big yay for really sticking with that and getting that done. Okay, second thing is I put up, if anybody would like to do study groups, I would love if you guys will reach out to one another if you need help studying. And remember, sometimes that's maybe more about helping someone else than necessarily that you need the help. But the one thing that I want y'all to understand is, and this is for recorded because I know I just have 3 of you here right now. I'm saying this to the whole class. If you don't feel like you're learning enough, or you don't feel like you're getting what you need and you're not showing up to Zoom, you know, really don't have a complaint. You need to be here every time we do something so you can connect with your classmates, as well as maybe there's some important information that you might be missing. And you can't replace the experience of actually coding together by watching the recording later. It's just something about being together and having that camaraderie. Rebecca, did you say something?
Oh, sorry.
No, you're good. Okay, so now I'm going to do our week at a glance for next week. So Monday, what you're going to have for Monday is very, very simple. You're going to have the ICD-10 Prep NCCT test. So because we're just coming out of ICD-10, I just thought it would be a great time for us to upload that little practice test and let you see what the actual practice test is, or what the actual NCCT test is going to be like. And then you're going to have a video. The Tuesday is your final exam. It will be our last day on Module 152. Matter of fact, your final will be your last assignment in Module 152. We're going to be moving into Module 153, and that will be a new class code, and I'll send that out for you guys on Monday. Because after you take your final, you're going to need to pop into your next class and see your Module 153 class and see what your next assignment is. And then what we're going to be doing is we're going to be just working our way through Chapter 8 for the rest of the week. I'm actually going to be putting little short lecture videos up for Wednesday, Thursday, and Friday that's going to go through the whole chapter. But instead of lecturing the whole thing, I'm going to break it up into little tidbits. And then on the 6th, which is next week, on Thursday, we'll do a Zoom call just to kind of talk about our week and if we have any questions on anything. But I'll remind you of that when, next week as it comes, so you won't have to try to remember. So, all right, are we ready?
Yeah.
Video.
I did call this speed coding, but we don't have to speed. We'll just get through what we can and see how it goes. You guys can see this? Okay, so our first scenario is earache. The chief complaint is right earache and ear pain. Now, this looks like a real medical note, guys, and I've had to break it into 3 parts, so just bear with
you.
the... Huh?
I can't see it.
Could anybody
Now
see
you're back.
It's not showing for me.
Oh, no. Okay. What about now?
Yes.
Well, I don't know why it wasn't showing. Okay, so everybody can see? Okay, again, this looks like an actual medical record of what you would actually print up or would be given by the physician. So the chief complaint is a right earache and ear pain. The history, this 20-year-old male is an established patient and well known to me. He is a full-time college student and presents with a right-sided ear pain, noted 810. Well, that's the date that he noted that it was hurting. The symptoms started yesterday and continued to worsen with no pain relief using acetaminophen. Denies discharge, hearing loss, or ringing, roaring. He denies trauma or recent barotrauma to the ear. He denies fever, sore throat, and cough today. He reports recently having a URI and resolved that with over-the-counter medications. That's what OTC stands for, over-the-counter. He is up to date on influenza, HPV, Tdap, his immunizations. Patient does not use tobacco, alcohol, or drugs, denies exposure to secondhand smoke. And here's his medical history that includes major depressive disorder with recurrent episodes of mild severity and bipolar II disorder. His current medications include aripiprazole and duloxetine, and there are no known allergies. Okay, so let's just stop and look at this. So what are we actually looking at? What's important for our diagnosis codes in all of this information?
The cause.
The chief complaint, right?
Cause of the pain.
Right. What are we looking here? What is his chief complaint? Why is he walking into the doctor's office today? Because he has he has right ear pain. Okay, now I want to ask you something. At the bottom under red, I said major depressive order with recurrent episodes of mild severity and bipolar disorder. Do we need that as part of our diagnosis?
No.
No.
No, we do not. Why? Because he's not there about that today, right? He's not there about that today. Is that right? He's not. He's only there for the ear pain. So let's go to our next slide, if I can. Okay, this is some clinical document. Oop, let me go back. Y'all don't look at that answer. In diagnosing otis media, which is what? An ear infection. Using the ICD-10-CM, you will need to document these characteristics plus left, right, or bilateral that are affected, and is the problem initial or recurrent to assign a correct code. So where do we need to go? I want you to open your ICD-10s and I want you to find me the ICD-10 code for right-sided ear pain noted. And you have to see the chief complaint says earache and ear pain.
Oh, you're so ferocious. You're so ferocious.
You sounded mean. I was scared.
Okay, guys, go ahead and mute if you've got noise in the background, okay?
How do I mute?
How are you?
I don't know how to mute.
Hang on. I muted you. Now I'm going to go back to my screen share. There we go. Okay, I'm going to wait just another minute and then I'm going to go ahead and go to the answer. All right, so the answer is going to be H66.001 acute superlative otis media without spontaneous rupture of eardrum, right ear.
That's not what I got, but
Okay, what did you get, Miss Lisa?
H92.01. Of course, I wasn't able to go up and down on reading everything too. I was starting there.
Okay. I'm actually looking at H9201 right now to kind of see.
Yeah, it's on page 866. Oh,
So you got H90.1?
no, H92.01.
Oh, H92. I'm sorry.
That's okay. I probably said it wrong.
Well, that's Oltelga of the right ear. We're
Okay.
looking for otis media. Sid, did you get that the same answer as I have?
So I went to ear pain.
What about you, Becca? Did you get the same answer as we got?
No,
No, what did you get?
I got H90 point something. I hadn't finished.
Okay. Alexis, did you get the same answer as I got? Can you walk us through? Hang on, I gotta unmute you. I can't unmute you, Lex. Can you unmute yourself?
Can you hear me?
I can. All right, now walk us through what your steps were, Lex.
Okay, I went to pain in an ear and I got the 92.0, but I was looking on the other way how to get it, and you go to Octus Media. Let me find it. Can I see your screen again, Miss Marcia?
Absolutely. I'm sorry, I know this is kind of a trial.
Quit kicking your blanket, fool. Oh, gee. You go to Octus.
The Otis Media.
Otis.
Okay.
Yeah.
Well, when we're looking right here, how would we know that we needed to look under Otis Media? Is that the a question that you would ask yourself? How do I know that we need to know that we need to look under Otis Media?
Okay.
How do we know that? Well, because Otis Media is everything to do with the ear. So it's not just pain in the ear because of you've had trauma. It's actually pain in the ear because you have an earache or an ear infection. So that's going to be Otis Media. So anytime that you guys see right-sided ear pain or earache or ear infection, that is part of Otis Media. So that's just one of those little learning things that the more we code, the more you're going to, remember that. So I'm going to go ahead and leave you with H660.001. You guys, I'm recording this so you can go back and look at it and rewatch the video and kind of do some researching in your in your ICD-10, sorry, in your ICD-10s so that you can see how they came up with that. So let's go ahead and reset and let's move to the next one. Okay. Our chief complaint says discuss laboratory results. So let's see what we're talking about. We're talking about anemia because we see that at the top. It says, a 38-year-old established female is seen by me over 1 week ago for decreased exercise tolerance and general malaise over the past 4 weeks. When doing her daily aerobics class, malaise is like fatigue. Labs were ordered on that visit. She presents today with pale skin, weakness, and epigastric pain. Symptoms are unchanged since the previous visit. Laboratory studies reviewed today are as follows. And we're looking at all of those things, and I don't really know what all of that means, but let's continue to move on. She takes that medicine for GERD with epiphagitis and reports taking over-the-counter antacids at bedtime for epigastric pain for the past 3 months. She also uses ibuprofen as needed for headaches. Current pain is 0 out of 10. Medical history significant for GERD, peptic ulcer, preeclampsia with the last pregnancy. Last menstrual period, which is LMP, 2 weeks ago. Normal flow, unchanged in the last 3 months. Married, 3 children, ages 15, 12, and 1 year old. Patient does not use tobacco, alcohol, or illicit drugs. No known allergies. No changes in internal history and review of systems noted from a counter 8 days ago. So let's go ahead and look at our clinical documentation along with our ICD-10 codes so we can kind of get a feel of what we're doing. So her gastroesophageal reflux disease needs to be noted, but let's go back and find out why. Well, first of all, let's look. She's iron deficiency anemia secondary to blood loss, and it's chronic. Okay, let's go back and look and see why. Okay. She was seen for anemia, right? Then she presents with pale skin, weakness, and epigastric pains. So who knows that anemia is pale skin, weakness, and weakness? That is a sign of anemia. How many of you guys know that?
Mm-mm.
Okay, anemia is a very common thing. So you need to become aware of signs and symptoms for it. Okay, so if I'm sneezing and have a runny nose, what can that be symptoms of?
Flu, cold.
Allergies, most likely sinus and allergies where we're at, right? But if I had a fever on top of that, that's when I would move into the flu. So knowing signs and symptoms of very common disorders or diseases is okay. Anemia makes you very, very weak, makes you very, very pale. And it actually tells us up here on the top of our medical record that that it's anemia. I think I cut off that she was seen for anemia up there. That's what it should say. And then if you're actually working for a hematologist or a doctor who does lots of blood work, you're going to actually learn what all of these things mean. But I thought it would be very, very interesting to actually put this in so you guys could go in later and look at what all of these things mean. So what are we actually coding? Well, we're coding her iron deficiency anemia. So that's the D50.0. And then this is the one that I wanted you guys to really, really see, is the gastroesophageal reflux disease with esophagitis. So why do we use that one? Why are we coding that one along with the iron deficiency? For this line right here, she presents today with pale skin weakness, which is the anemia. And what does it say here? Epigastric pain. Symptoms are unchanged since the previous visits. So do you see why we use both of those diagnoses?
Yes.
All right. So I'm going to let you guys do this one. I'm going to read it, but I'm actually going to let you go to town on this one. So the scenario is abdominal pains. The chief complaint is my stomach hurts. Patient is a 65-year-old male admitted to the hospital with abdominal pain. He has a history of Crohn's disease of the large intestine. He also has a history of coronary artery disease and had a heart attack 5 years ago, but has had no problems since then. He smoked cigarettes for 45 years, but quit after his myocardial infarction. He also has a history of allergic reactions to penicillins and the cephalosporins. I don't know what that is. Oop, shoot. I don't know why I did that. I put our clinical documentation along with our answers. So let's talk about what do we see is actually a viable diagnosis code. Make a list. I'm not asking you to code it. I'm asking you to make a list of what you think are the viable diagnosis codes in the scenario. It's okay. They're coding. Do you need some?
Hey.
Alex says, hey.
All right, I'll just help you.
Yeah, okay.
I don't care, Raya. Go. Do what you want. Bye.
Okay, do we have a list?
Abdominal pain.
Hang on, let everybody.
Crohn's.
Okay, well, I'm going to go ahead and switch to the next slide so we can see the list, okay? There we go. Crohn's disease,
Got that one.
old myocardial infarction. Look at how many Z codes we have, ladies. Personal history of nicotine dependence, allergy status to penicillin, allergy status to other antibiotic agent.
Why would you not code abdominal pain when that's what he was going in?
Okay, let's see what the clinical documentation says. Crohn's disease is separated by small intestine. Okay, so do you know what Crohn's disease is?
Something to do with your digest.
It actually is abdominal pain. That's how Crohn's disease can present itself. So even though he didn't say specifically Crohn's disease, the abdominal pain is directly related to that Crohn's disease.
Of the large intestine.
Yes. So do you see that?
Yes.
How they're linked? I know that these are different, but guys, I wanted them to be different. I wanted you guys to be able to think about coding in a broader way. So did you guys get the allergy codes and the personal history codes? Did y'all write that down?
The only three I wrote down was abdominal pain, Crohn's, and allergies.
Well, you got two of the allergies, but we have to pay attention to those personal history codes. Personal history codes and allergy codes and counseling codes, those are all Z codes. Who can tell me that they've gotten in and did their Z codes the way I have? I need a sound off. Who's done it?
Okay. This is strictly for report reason, not billing reasons, right?
The personal history codes?
No, this scenario here, are we going to bill him for all of this?
Yes, ma'am.
Okay.
The personal history codes are not going to pay as primary diagnosis codes or the allergy statuses because he's not actually going in for the fact that he had an allergic reaction to penicillin. It's just telling his story. He's actually going in because he has Crohn's disease and it's causing abdominal pain. The old myocardial infarction is just, again, it's a history. It's something that's going to follow him all the time. But he wasn't being seen for that, was he? Why
No.
do you think that you need to include those history codes?
So you know their past history?
Right. We're not talking about a past history of a malignant neoplasm that is now cured and is in remission. We're talking about things. He has coronary artery disease. I'm going to tell you, I would have coded I-2510 to go along with that. Because you see he has a history of coronary artery disease and had a heart attack 5 years ago. Why wouldn't you put coronary artery disease? I would, wouldn't you?
This internet's being a pain.
I'm sorry.
No, it's probably on my end, darling, because it's been going off and on all morning.
Okay, so remember you guys I'm gonna upload this video. I want you to go back, and after we get done talking about it, I want you to take time to code it. I'm gonna put it in a post, so it's not gonna have a due date on it. So that way you can go back this weekend if you want and look at it and really, really, really think about it. I didn't hear anybody speak up and say that they bubbled and highlighted those Z codes. I've shown you over and over and over again how you're going to be able to remember these personal history codes and all these things. We see Z codes almost every time we code. So let's look at what could be wrong with Mr. John Jackson. So many times when we meet a patient, we're going to be able to see with our own eyes what some of the signs or symptoms are, aren't we? Looks like he is trying not to get COVID.
That's what I was gonna say. Araya Payton. Hold on while I mute myself.
And what could be wrong with Mr. Smith? Y'all give me some options. I want to see what you think. Just by looking at him, observing him, what do you think could be wrong with Mr. Smith?
Kidney infection.
Miss Lisa, that's what I was thinking too, but I thought somebody was going to jump to something else. Somebody give me something else. Sydney, what do you think could be wrong with him?
Lower back pain. Anything
Lower back
lower
pain.
back.
Yeah, absolutely. What could be something else? If he was a girl, he could be in labor, right?
Right.
But that's what I was looking for, Miss Lisa. I was looking for somebody to give me something that isn't necessarily the obvious answer. This is how I want you to begin to look at your coding. Sometimes it's not the obvious answer. I want you to keep an open mind as you do your coding scenarios. I know these were a little bit different. They were a little bit odd. I planned it that way because everything isn't going to be as straightforward as code diabetes mellitus. Some things you have to think outside the box. Not most things, to be honest with you, not most things, but some things. So I want you to really, when you get a scenario that doesn't necessarily make sense, I didn't agree with all of those codes. I would have added a code. I thought the coronary artery disease should have been in along with that myocardial infarction, an old one. I've never coded an old myocardial infarction, and I was a cardiology coder. So just because I code something one way, and Sid, you may look at it and code it a completely different way, because coding is not always black and white. It's how you read the medical report. That's why there's range of codes. And that's why I always say, make sure that you're being specific as you can be, right? Because I saw something in that scenario that the person who coded it did not see and did not think was important. So you understand how that can be a little bit different, and it's all about the coder. So anybody have any questions or anything to say?
No, I'd just like to say something about, I've been going to the doctor with a friend of mine, and I noticed on her statement, is this something they just started doing or always have done?
Well, you froze, and so all that I heard is I noticed on her statement, and then it stopped.
Oh, okay. On her statements, it's been given all her codes of all the procedures and stuff, her diagnosis and all.
Are you talking about her encounter form or her explanation of benefits or what?
No, everything that they did that day. It's an explanation of what they procedure done. It's called a Z12.31.
Well, that's a diagnosis code, not a
Okay.
procedure code. Well, actually,
Okay, diagnosis.
Do you want to know why you're noticing that now? Because you're doing that now. Because you
Okay.
know what you're looking for. Before, you wouldn't have even known what to look for, right? Now, every
Right.
time you go into something and you see you're sitting in a waiting room waiting for your mom to have foot surgery. That's me. And I'm coding the surgery and giving the diagnosis while she's in there. All of a sudden, your world is different. You don't see signs and symptoms just as signs and symptoms. You see them as alphanumeric codes, or how would you treat this, or, or where's the place of service, and would you need a modifier? It changes the way that you look at what you see in healthcare every day.
Yeah, because it had every code.
Ma'am?
It had every code that they did that day.
Yeah. Did they get the diagnosis codes too?
I didn't really realize that they actually put the billing
Yeah.
code on there.
When you work in a facility, guys, if you work in a office, they have these encounter forms, the super bills, and the doctor checks what actual CPT codes he wants you to have. And then at the bottom, he lists ICD-10 or diagnoses, and you assign the ICD-10. That's what I did. But if you're coding surgery, you code from a medical record. So if you work for a facility, it's actually very simple. I'm teaching you the hard way. Even if you code surgical stuff, because you'll be in a specialty like me, cardiology, then use the whole CPT manual. I just used a small portion of it, and I didn't even use all of those codes, because here we do very specific things. My doctors did very specific things, and so my range wasn't huge. What I'm asking you to do is to code everything in a huge range. Some stuff you like, some stuff you're like, oh my goodness, fractures. I don't care for fractures. I love the digestive system. It's my favorite. The integumentary system is my favorite. So when you get into a specialty, say for example, Sydney gets a job working at open air MRI, and all she does is radiology. Well, she's going to know everything there is about radiology CPT codes, and anything that diagnosis wise goes with that, because she's in that specialty. If Alexis goes to pediatrics, same thing goes for her. She's going to know all those things. They're repetitious. What we're doing in class is we're trying to get a little taste of everything. Does that mean that we need to remember everything? No, we remember the processes, and then we remember how to go out and find what we don't need. You'll see. Hi, Phelan. Anyway, okay, any more questions?
Is the coding packet 3, are we supposed to start on 31?
I don't know.
It's on Edmodo, and we just have